Thanks, Quinton. Can everyone hear me at the back? Yes, there's a few nods. This is a talk about doing nothing, and it's a bit of a talk about clinical decision making. So there's an overlap with the talk you've had previously, and I think the message that Pura and I are sending is reasonably consistent, which is pleasing. So very standard boilerplate disclosures. If any of you have gifts you want to shower me with, overseas holidays to my family, and want to add to my list of disclosures, please feel free. But I'm not representing any of my employers or academic affiliations. I'm just a bloke enjoying an awesome conference, and I'm going to give half back to the tax office. So thanks Quinton and Dylan for that. Look, I don't think what I'm going to say is earth-shattering. I don't intend to say anything controversial. I don't think what I've got to say is brilliant. But if you think something I say is brilliant or something is controversial, just email me and we can sort of get in touch and smooth those things over. Chances are I probably haven't properly represented what I want to say. This is a talk about doing nothing, but the central missive is that doing nothing in healthcare is actually something. So this is a quote that was originally attributed to the White Rabbit, when the White Rabbit first met Alice in Disney's 1951 depiction of the Alice in Wonderland. And it's a quote that has been reused and respoken over time by people such as Dwight D. Eisenhower. So don't just do something, stand there. So we're here to talk about what I've termed as expectant management, which we'll soon find out is not actually just doing nothing. And it's a talk about clinical decision making, and we're talking about clinical uncertainty and why that bothers us. And I'm going to try and encourage you all to be brave in the clinical decisions that you make. I'm going to briefly touch on concepts of shared decision making and risk management. And my only party trick really is kind of medico-legal things. I do work for a major NDO, so there's going to be a bit of a medico-legal spin to it. My clinical work is as an emergency medicine specialist in Canberra, so that's the perspective I bring. So half-time clinical, half-time kind of looking at claims, negligence claims, professional conduct claims against doctors, and I've been doing that for the last 5 years. So what is expectant management? It is a wait and see approach, and I guess the words mean something. That is, you need to both wait and you need to see. You need to actively observe. Expectant management accepts that time can be a diagnostic tool, and in fact probably the best diagnostic tool. It allows the clinical information to become clearer and therefore direct what we do with patients. Expectant management acknowledges the harms with over-investigation, and I think the story that Pura told us right at the end is very poignant and a very concerning story. And expectant management is actually patient-centred. But like all of the things we do to our patients, we need to practice safe medicine. This is my gift to you, this QR code. Now, I've not written a book, but if you read one article in medicine this year, read this. Perhaps on your way back to where you're from. It is one page. This is a general practitioner suggesting that, in fact, the best medicine for his patients is a tincture of time. So tincture of time is not a nightclub in Koh Samui or a cocktail you might find at the bar here. A tincture is a sort of ethanol-based sort of, well, it's plant extract sort of soaked in ethanol, consumed for medicinal quantities. And this general practitioner suggests that a watch and wait approach is often the best approach in some circumstances. He described the context of how he practiced. So I'll just read it. He says, "In Canada today, there is no deterrent to using medical services, and I see people coming in earlier and earlier with vaguer and vaguer complaints. The stoicism of the past is dying to be replaced by a hyper-anxiety of rare disease societies that claim the least symptom might be the first sign of a horrible end. Individuals are encouraged to flock to their doctor's office in droves. The context he was practicing in was rural Canada, and the year was 1981 when this article was written, right? So sometimes the more things change, the more they stay the same. We often grapple with the decision to whether we observe or intervene more often than what we think in acute medicine. And I've just noted a few examples, and some of you will have examples of your own that you can think of as well. Often we need to make decisions as to the timing of intervention. And the classic one that sprung to my brain when I was kind of writing this talk was airway management. When do we intubate that tox patient with a GCS of 7 or 8? There was a recent study that suggested that we could probably wait a little bit longer, and there's harms around intubation. All right, but you know, it takes experience and it's a judgment call, right? In just deliberating whether we kind of think to investigate a patient, we're often left with a decision about, do we do that scan? And if so, under what circumstances? Has that patient in front of us met the circumstances for when we think we need to do that scan? And then what are the potential harms? And any time we sort of discharge a patient from our care, that is an active decision, and we need to think about what sort of advice we're providing for patients. And I'll talk to that on some of the subsequent slides. So expectant management is not doing nothing. Most of you would remember Seinfeld. This was classically a show about nothing. It was not a show about nothing. A show about nothing doesn't run for 9 seasons. Seinfeld was a show about the trivialities and the mundane activities of everyday life, amongst other things. And I guess in medicine, it's the details that matter. It's the trivialities of circumstances that are in front of us that we need to appreciate and grapple with. Expected management is maintaining a cat-like state of readiness, right? Being poised like a puma in the savannah, ready to pounce. That's what I think expected management is. Expectant management is not dithering, right? Expectant management and conservative management, or whatever term you want to use, is an active thought. It is not just a passive decision, right? So if you're Luke Skywalker and you've crashed your X-Wing into a swamp, right, and you need to use the Force to get the X-Wing out of the swamp, as Yoda said, you need to do or do not, all right? So make active decisions about how long you're going to observe patients for and what you plan to do. And your path you must decide. So what are the challenges in expectant management or conservative management? So most of us are scientists in some sense, or science kind of resonates with us. That's why we chose the vocations we chose. We pursue certainty, all right? And we need to make sure we don't pursue certainty at all costs. You've probably heard this before, but we don't really make diagnoses in medicine. We probably just evaluate for risk rather than to actually make a robust diagnosis. And often a certain diagnosis is elusive. And what we do in emergency medicine is we aim to be certain that the patient in front of us does not have a life-threatening condition. despite what we think, we're not good at estimating disease prevalence. And I'm just going to sort of make a few points on this. If we accept that we're all product of our training, we have to accept that experience matters. So I think back to how I was trained as a medical student. So we got dispatched to various parts of the hospital to speak with patients. So if we were doing a long case, I would have got sent to the coronary care unit. I would have introduced myself to a patient. They were at hospital, they were monitored. Their bed card listed their admitting physician as the professor of cardiology. In 1996 at the John Hunter Hospital, if you asked someone what brought them to hospital, on about 50% of occasions you would get the answer being an ambulance and then a chuckle, right? And then they started off by saying, look, I had a heart attack. And so you'd know the diagnosis, and in fact you already knew the diagnosis because they were in under a cardiologist, right? They had chest pain, like what else was it going to be? And then you worked backwards, took an overly elaborate history about what sort of pets they had, when they last travelled overseas, all those sorts of things. And you eventually sort of presented the case. So you finished medical school assuming that everyone that you'd ever met that ever had chest pain was admitted to a tertiary hospital under a cardiologist. All right? And then you do your emergency medicine term. All right? And it takes years to get a really good grapple on what pathologies patients present to emergency departments are. There's an urban myth that the famous painter Pablo Picasso was sitting in a cafe in Paris in his sort of senior years. And he was doodling on a napkin, right? And it's Picasso, so it was probably some sort of cubist masterpiece, right? Like it wasn't just planning graffiti for a toilet door, okay? This is Picasso, so he's doodling on a napkin. And a lady came up to him and said, look, can I buy that napkin off you? And Picasso said, sure, 1 million francs, right? And she said, you're kidding, it took you 2 minutes to draw. And he said, no, you're mistaken. It took me 60 years to be able to draw this, right? So experience matters in healthcare. We're a product of our training and we're a product of our experience. Sometimes, and this I guess relates to the previous talk about biases, experience can be replaced on occasions by cynicism, all right? Think about the last time you saw a patient in the hospital with a seizure, all right? The youngsters run towards the fitting patient, ask for the midazolam to be drawn up, and the old sages in the room sit back and kind of go, yeah, nah, it's a pseudo-seizure, right? And maybe it is, maybe it isn't, okay? But we often approach clinical problems with inherent bias, and we're a product of our experience and our training. The system encourages need for certainty, all right? And it can be location dependent and can be driven by what resources are available. So I sometimes ask my resident staff, I say, what's the most expensive item in this hospital? Right? I get a few blank looks. And you know, the answers come up as, well, the MRI scanner, I don't know, the CEO's desk, answers like that. And the answer I give them is it's the intern's pen, right? Because the intern pen just sort of orders all these useless tests patients don't need that taxpayers have to pay for, right? And it's the intern's pen. And I'm now waiting for one of my resident staff to butt in and say, but David, we don't carry pens. So I'll have to, in the DHR sort of New World Order, I'm going to have to say the most expensive thing is the intern's login, right? Which, you know, I think it is. But we're driven to make decisions by availability of resources. What's the most expensive investigation you can order is another question I ask my resident staff. And the answers are predictable. Oh, an MRI, right? The most expensive investigation you can order is an overnight stay in hospital for observation, right? And that's north of $2,000. Okay, well, at least that was the figure quoted to me by the hospital's CFO some 7 or 8 years ago. So it would be probably closer to $3,000. Which is why, if you've got abdominal pain in the emergency department, you get a CT, right? Because a CT is what, $400? Keeping you in hospital, $2.5, $3 a day, and then you may or may not have resolved the problems, right? So we're a product of our training, a product of our experience, and we need to work responsibly in the systems that we work in. So be aware of all of that. All right? I'm not saying that's all wrong. I don't think we can sort of change the systems, and we sort of get it. You know, perhaps if I had a bit of tummy pain, I wouldn't mind a CT. I think that's not a bad strategy. Patient circumstances have to allow for expected management, okay? And we know that it doesn't always work when you need to rule out time urgent problems, right? So if a patient needs a CT, if they've got sudden onset intrascapular pain that they describe as a ripping, tearing quality, and you think they've got an aortic dissection, and you're well aware that any delay in diagnosis and management of that will increase the mortality rate by 1% an hour, get a CT, don't dither, right? If you need to use the force to lift the X-wing out of the swamp, we'll just do it. In the hospital environment, I think we have less visibility over care provided in the community than we think. I know I do. I think my career in emergency medicine has been fairly linear. I was an intern, resident, registrar, passed a few exams, out I came. I didn't do general practice, worked in a few rural sort of base hospitals, but never worked remotely, okay? I don't think I'm the authority on what a GP should be doing in their own surgery or a referring doctor should be doing in their own clinic or their own hospital. I think we need to sort of grapple with that before we give advice or cast dispersions on others. As was mentioned in the last talk, a lot of ED KPIs exist, and we have to work within that system. But I think the last time I checked, every ED KPI is based on speed, right? And the assumption is that, of course, speed in some circumstances might equal quality, but it's really difficult to measure quality healthcare. It's impossible. It's easy to measure time. You can measure that very precisely, or money. Measuring time and money, no problem. Measuring quality, much harder. I don't think I can give this talk without a few comments on sort of clinical decision rules. I think they're great. There's a lot of them. I read somewhere that there's even a clinical decision rule on how to devise a clinical decision rule. I don't know if that's true, like the story of Picasso in the cafe. I don't know if that's actually true. But, ever since the sort of Ottawa ankle rules in 1993, I think there's clinical decision rules to provide for a wide variety of circumstances. They're much better applied when you have simple problems, and more complex problems require more thought and a better history and a better examination. And experience matters. In my medico-legal job, one of the things that I come across time and time again when I look at claims is that the history and the examination probably haven't been good enough for those circumstances, all right? It's the clinical history, so taking the history and listening to the history, two distinct things, where you get really most of your answers right. I reckon I solve most of the problems, about 75, 80% of occasions, by good history, supplemented with an examination that informs your decisions as to whether to order tests or not. All right, it's just a theme that comes up. All right. Back to the comment about KPIs and speed. There's so much pressure in emergency medicine to decide if they need a scan to go and do it. Some of those shortcuts I think are problematic. All right, it's just what I see in what I do. And often the clinical decision-making rules contain a degree of gestalt, which you can argue defeats the purpose of applying the rule anyway if you've got to think within the rule as to what you should do. But that is how it is in some rules. And then when the literature does compare clinical decision rules to unaided physician judgment, the rules usually are not superior, right? It's not a statement to say that applying clinical decision-making rules doesn't have a place in medicine, but you're the decision maker. Doctor, nurse, paramedic, you're the provider on site, right? You need to take the history, do the examination, and then use the tools that can help you, which may include clinical decision rules. I'll give you a few comments about my approach, right? Like, I order a lot of tests, I do. I'm not saying that I don't. I order a lot of tests, but where I do order tests, I try and be as rational about ordering those tests and ensuring that the information that I have is the best information that I can get to informing me as to whether those tests are appropriate. Right? When I review patients with resident staff, most of the time I am reviewing the patient for the sole purpose of retaking the history. All right? And the history that I then take is focused, directed. It's answering the clinical questions that are running through my head when I hear, the resident's version of the history. All right, getting information from the patient, retaking that history, is really important. And there's numerous occasions where the history retaken at a different time, yields a different outcome. And I'm sure sometimes I've had residents come to me and say, well, the patient didn't tell me that, they've lied to me. And I think, well, okay, that's fine. But this is the way I asked the question. This is the answer I got back. How did you ask the question, right? We can have a discussion on that. But I get it, sometimes, there can be some confusion in the information that you get. But I think as professionals, we're the ones that need to take responsibility for ensuring that we get a good history, all right? And again, I've touched on this. If the patient needs a CT for their life-threatening condition, get the CT, don't dither. So a few comments. So a lot of expectant management is around patient communication. That's the key skill. I explain to the patient what I'm thinking about that might need exclusion or might be a life possibility, and I'll give information based on that. So, for example, so I've had a child with tummy pain, 5-year-old, right? And I say where it hurts, and they always point to their belly button, right? You examine I'll make I really examine the abdomen slowly and methodically with the parent in front of me. And when I press on their iliac fossa on McBurney's points, I watch the child's face, and I say to the parents, if the child's not tender at McBurney's point, I say, look, I'm pressing right over where their appendix is. If your son or daughter had appendicitis, they would not like me doing that. And see, I can push quite firmly into their abdomen and it's not causing them any pain or discomfort. Right, I think that's really powerful. You've just showed the patient what examination is being conducted to assess for appendicitis. And I say things like, well, appendicitis is the condition that we're thinking might be a possibility here, but on examining your child, they're not sore over their appendix. It's possible they may become sore over their appendix, so if they complain of pain over their appendix, we should see them again. But at this point in time, I don't have enough evidence to suggest that they have an appendicectomy, right? And it's about communication. Another point, and I guess this talk is probably sort of a loose sort of collection of kind of tips on a theme, but don't get in the trap of offering investigations unless you can actually deliver on it, right? So don't promise admission to hospital if that's not your decision to make, if you have to go through a registrar or another consultant, right? The language is, well, I think we should observe you longer. I'm going to get my surgical colleague to come down and have a look. So don't offer investigations unless you're actually willing to follow through on that. Sometimes I ring the patient's GP or specialist. Look, that's a luxury of working day shifts, which I really enjoy. Obviously, when I work evenings, night shifts, that's not really possible. But short sort of conversations with referring specialist GPs are often really useful. And I really ensure that I don't just pass the buck back to the GP. I mean, we all work in resource poor environments, whether as nurses, paramedics, emergency physicians. GPs also work in resource poor environments. And the patients ended up in your emergency department for some reason. So I try not to sort of just pass it all back to the GP. I try and actually add some value. And most of the time I can, either through some tests or a conversation with the patient or a few suggestions to the GP. One sort of point to make is when I observe patients, I set time-based parameters and I actually stick to them, right? So how many times, I've lost count on the number of times one of our residents or registrars will come to me and said, look, I've got this kid, they're a bit febrile, I'm not sure if they can go home. And look, I think perhaps, someone should review them at 7 o'clock, right? And you go, okay, cool. And right, their shift's finished at 6, right? So usually that hour to which someone should review them is sort of n plus about 1 or 2, where n equals the time at which that doctor's shift finishes, right? And we end up observing kids, at least in my ED, for a really long period of time, far longer than we need to, right? You don't need to observe kids for 7 or 8 hours, right? Often the answer was present at hour 3 or 4 as to whether they can go home or not, right? So if I'm observing a kid, so whether they've got a fever, whether I'm sort of stretching and with salbutamol, I say to myself, right, I'm going to see this kid at 5 o'clock. At 5 o'clock, if I can discharge them, I'm going to discharge them. If at 5 o'clock I can't discharge them, I'm going to do some blood tests, right? Or I'm going to ring the paediatrician, or I'm going to arrange admission. And I really try and set these time-based parameters and stick to them, right? Because we have a bias, we're all busy, we don't want to intervene, and that's okay. Now, if my resident said to me, look, I'm really not sure what to do with this kid, can you come and see them and give me a second opinion? That's fine. But, look, at 6:30, can you make the decision? Because I'm going home at 5. I think it's probably not good enough. So, shared decision making, it's a concept that's sort of in the literature, most of you would have heard about it. It's the concept of sort of allowing a patient some input on the decisions to be made about their healthcare, completely consistent with quality healthcare, right? Because we don't bear the consequences, the patients bear the consequences. So you just need to be careful to not pass the buck. I have seen occasions where complex decisions need to be made. So, right, if someone has, so if a woman turns up who's, say, 25 weeks pregnant, a bit short of breath, and the really live question is, should they have imaging for a PE? I think we need to provide a recommendation on that, and we need to sort of spell out what are the pros and cons. I think if we say, essentially, that we don't say these words, if we say, look, gee, I've been doing this job for 20 years, I've seen probably 100 patients like you, I've read some literature, I don't really know what to do, you're a high school teacher, what do you think? Right, which I have seen on occasions, that's not good enough. So I think we need to actually provide some recommendations. We've got to provide some basis for our recommendations, and where we have gaps in our knowledge, acknowledge those gaps. But yes, the patient is the one that needs to bear the consequences. The other problem I've seen with some of these sorts of shared decision-making conversations is where the provider essentially talks the patient out of what's entirely a reasonable strategy, right? Because it's convenient for them. So imagine you're seeing a patient, thunderclap headache, had a CT that's basically normal, you feel they need a confirmatory test, it's 10:30 at night. I have seen my registrars essentially talk the patient out of a lumbar puncture, where a lumbar puncture would have been a perfectly reasonable thing to do because it's 10:30 at night and the registrar wants to go home. Okay, and then the answer I've got from the registrar is, oh well, I offered a lumbar puncture but the patient refused. Be aware of your own biases and try and be as objective as you can in the situation. If it's your clear recommendation that the patient shouldn't have a lumbar puncture, and if it was 10:30 in the morning and you had a logbook to complete, right, would you do the lumbar puncture or not? And that's probably a valid question, okay? So emergency medicine is not just a game of poker, even though statistically most of our patients go home. I think the advice needs to be a bit better than come back if you're worried. All right, I think we've got to be quite clear with patients what signs or symptoms, should they develop, would mean that we want to see them again. And there does need to be a system of following up outstanding results. So medical imaging tests that get reported later on and pathology results that become available. I think hospitals need to have robust systems to convey that information to patients. I think clinicians should have input on those systems, but we work in systems. Discharge summaries need to actually be a summary. The GP is often the expert on the patient, we're not, so the past medical history is often well known to a GP that they've been seeing. Include a plan insofar as you can, right? Don't box the GP into a corner to do a particular test or another. The language I use is, your doctor may wish to consider X rather than go and see your GP and ask for a Holter monitor. I think that's unhelpful. And I think one thing to say about documentation is it can be such a good opportunity to collect your thoughts, right? And so document contemporaneously in the moment. Right, so documentation is like writing a story, and if the story that you're writing doesn't make sense, right? So you're saying, oh well, the patient's turned up again, tearing intrascapular pain, worst I've ever had, family history of bicuspid valve, and your plan is, go home, follow up with your GP, manage your anxiety. And you're writing that down, and sometimes you have moments where you do that. You go, actually, this is just ridiculous. This story that I'm writing doesn't make sense, and you can go back and make those corrections, take a better history, change what you want to do. So it's not a talk by someone that does Medico-Legal that doesn't include documentation, right? I have to mention it. It's sort of an unwritten rule. Got to talk about notes, but just make sure the notes make sense, and just use it as an opportunity to actually think about what's going on with your patients. Look, I won't dwell too much on this because we've got 2 minutes to go, but look, we're not, Medico-Legal talks are a bit depressing, right? Like no one wants to come to Thailand to talk about getting sued or how to navigate the complaint system. But if you provide quality patient care, you'll get fewer Medico-Legal outcomes. And we have to provide reasonable care. There's some cases that examined implementation of, it's an ACT case actually, that examined expected management where the implementation was far from best practice. I read the case, it was far from best practice. It was the right decision, but the way it was implemented was not best practice. And that doctor was found to not be liable because the decision to watch and wait was reasonable. Clinical context is everything. So in that case, this was the first presentation. I'm sure the courts would have made a different decision if this was the second or third or fourth presentation. So repeat presenters, do sort of keep your wits about you, and acknowledge when expected or conservative management has failed. We try and sort of follow up, ensure patients get follow-up. There's some legal authority that suggests that referrers, in some circumstances, are not liable when there's delays in the public system. We still have to advocate for our patients. This was another ACT case, which was very interesting. I can bore you with that later, probably not now because I think the beach is calling. But essentially, in civil matters, your care is judged on what is peer professional practice, which needs to be widely but not universally accepted. It's bang on 10 o'clock. I'm such a stickler for time. I'm going to hang around the front. If any of you got any questions, come up, we can have a chat. But I'll hand you back now to Quinton.